Hello, everybody. Welcome back to the B School. Be better, be empowered. I am Dr. Emery Pitcel. I am joined today by Rebecca Hall, and she is of Happy Valley Bodyworks. I'm really excited to have Rebecca on because while this is our seventh premiere of the B School, this is the first one that Rebecca is joining us. So, Rebecca, take a moment to introduce yourself to everybody, please.
Yeah, well, thanks for having me. I'm very excited to be here.
Yeah, thank you.
Yeah, absolutely. Um, like Dr. Emery said, I am a massage therapist. I'm also an athletic trainer, so I have kind of a dual credential background. I work at Happy Valley Bodyworks here in State College. I provide services basically for both the massage side of things as well as some athletic training services as well. Kind of a broad background, but really excited to kind of delve more into today's topic and chat with you.
Yeah, and you are still with Penn State University part-time, right?
I am. I actually work with a field hockey team there as well, so I keep myself very busy.
That's awesome. So Rebecca has a ton of credibility when she's talking about like athletic injuries. She's walked the walk and talked the talk. So just all the more reason that we feel so excited to bring you on and talk with you today. And also, what a great asset you are to our Center County community,
Well, thank you.
and whatnot there. So today we are going to jump in, like I said, episode 7. It is March of 2025 here.
Crazy.
We are going to go into the front of the knee pain. For those that know maybe a little bit more anatomy and everything, they have heard of anterior. So anterior means the front. So just so you know, if throughout the course of this podcast, if we start saying like anterior knee pain, we really mean the front of the knee, okay? And we landed on this topic because we figured, hey, this is the month that the weather starts to get a little nicer, right? And
Yep.
so as a result, we know some people are going to come out of their hibernating shell and probably try to go from 0 to 60 activity a little too quick. So we wanted to have some information out there to kind of let you know that if you're that person, you're not alone. This actually happens more common than you think.
I'm one of them. I'm guilty of it.
Oh, you're not supposed to admit that to everybody. So on that note, I'm going to start with some epidemiology stats, actually. So we mentioned that it is actually not incredibly uncommon. There is a European orthopedic journal, a knee surgeons division in this paper that actually estimates that around teenagers, adolescents, that around 40% of female athletes have some sort of mild to moderate to severe anterior knee pain, right? So that's not insignificant. I mean, you're going to
Definitely
grab
not.
4 out of 10 high school athletes and female athletes, and you're going to say you're probably going to have some sort of knee pain. I think the male statistic was more like a 25%, 40%. And then the estimation is that probably the general population, as far as front of the knee pain, it's about a 20% if we're doing like our entire general populace. So 1 out of 5. So if you jumped yourself back to activity and you're like, I have knee pain, this stinks, you are really far from alone at that point. And actually, this is kind of a perfect segue for us. I was just talking about female athletes, and I know we were having a little discussion before we jumped on the call here, and you had some awesome insight on that. Would you kind of want to elaborate a little further on that for everybody, please?
Yeah, definitely. Dr. Emery and I were really talking about how the shape of the hips of a female versus a male can actually really, really affect that pain and like your likelihood to have pain. So females typically have wider hips, which causes what's called a greater Q angle. So the Q angle is basically the angle, if you think about the hips here and then where your knee is positioned, when you're standing, the female is going to have a greater angle from her hip down to her knee than a male. Males tend to be more straight. Females tend to come in more. That's why a lot of times we see more prevalence of ACL tears and other injuries to the knee in females versus males. Super common because of that.
Yeah, right.
Because that angle just changes the way that your body is able to transfer force, right? The other thing we were really talking about is female hormones, right? So we all have cycles and in our menstrual cycle, right? Sometimes in different parts of the cycle, we actually have these hormones released that relax our body and relax the ligaments in it, but it can actually cause a lot of pain when your muscle or your ligaments are looser than you're used to and you're trying to do all of these activities. So just some interesting things as to why maybe some of this knee pain can come up other than what we're going to discuss here later today.
Absolutely. Well, that's fascinating. I thought that was really informative when we were talking about that before, and I'm like, let's make sure that goes into the podcast so everyone can learn a little bit more about that.
Yeah.
We were starting to allude to this already, but we want to jump into our next point and say like the cause of pain. Now, much like most musculoskeletal injuries, would you probably agree with me, Rebecca, that a lot of injuries are a combination of like the two extremes? We either have complete inactivity that can cause knee pain, and we could
Hmm.
also have the very obvious that we were kind of already alluding to in the beginning, overactivity with like athletes and everything. So
Definitely.
how about you tack on some of like the athletes, like what are some of like the causes and kind of like the common things that are going to create that front of knee pain?
Yeah, so I see it a lot, especially with the running population, right? So I
Yes.
work field hockey, so we do have some running involved, and especially their conditioning sessions, we get a lot of athletes that will have that anterior knee pain because they're not used to the pounding. Now, it can be due to, shoe type, it can be due to the surface, the changing surfaces that they're running on. But it can also be due to, again, we talked about that Q angle. Some of the times it's just like a muscular overuse, right? So if your muscles get really tight or your tendon's not used to being pulled that way, that can be a cause. So yeah,
Hmm.
the fun thing about anterior knee pain is there's not usually one specific like this is the uh, this is the cause. So sometimes you got to kind of rule out a couple different things first.
And it's kind of like a stew. It's probably usually if you are in the overactivity, it's not like it was just this one specific thing you were doing.
Hmm.
It's like, okay, it was the way you were running, it was the shoe that you were in. It's like the lack of conditioning that you have for actually strengthening like your quad muscles. It's probably like a lot of small factors that
Hmm.
none of them by themselves sinks the ship, but when you put those stones over top, it brings everything down, right?
That's what makes
Yeah.
chronic injury such a challenge.
It does. It does. So, yeah, definitely. I think we were talking quite a bit of the running athletes as somebody who ran cross country, track, and field
Hmm.
through college myself. I ran into plenty of issues. In fact, they actually call like the typical patellofemoral tracking or the patellofemoral pain. It does actually frequently just get the nickname runner's knee, right? Or like,
Hmm.
yeah, and whatnot. Or we also have like a jumper's knee as well too, which is also going to pretty much be on the front of the knee and kind of effectively be like a like the patellar tendon has like a tendonitis, correct?
Hmm.
Yeah. So then once we get, I know we're spring here, so track and field's not far away. We're thinking
Hmm.
like the long jumpers, the pole vaulters, the high jumpers, correct?
Yep. Yep.
Um, Certainly, I know you get the outfielder that needs to jump up in baseball, right?
Oh yeah.
I actually have another person that I'm going to pick on in baseball. Sorry, baseball players, but catching, being the catcher has got to be one of the toughest things on knees, just like that constant load in that deep squat,
Hmm.
correct?
Yeah, and that's the other thing I was going to mention, right? So we have our running side of things, but
Mm-hmm.
also if you're lifting, right, that
Correct,
can also
yes.
cause anterior knee pain, right? Especially if you're lifting too heavy, your form's not right, you have some weakness and you're compensating because you're trying to lift too heavy of dumbbells, maybe trying to be too cool at the gym or something. We've all been there sometimes, but I think sometimes that can also be a really significant cause of that
Yeah,
that deep squat motion if you're
yes.
not having the load if your body's not able to hold that load, it can
Mhm.
also really cause that anterior knee pain.
Yeah, yeah, absolutely. And I think that all got hit pretty well. And we alluded to from the beginning to the weekend warrior, where you went from it's that first spring day that's nice. We all know it's coming, that first 70-degree weekend, and you're like, I'm going to go run 2 miles. Well,
Hmm.
if you haven't ran 2 miles in 6 months, your whole system, your whole hamstring, quad, and just knee joint, and just everything neurologically, muscles, soft tissue, joint wise, it just might not be up to the task on
Right,
that.
right.
So going to the other extreme though, inactivity, because we don't want to just sound like we're tailoring this to just athletes, because we definitely see lack of activity be a major problem. Sedentary, we have a lot of people that work desk jobs that maybe don't
Hmm.
stand up and get up quite enough. We're going to get into this a little bit later when I go over assessment philosophy, but when you're sitting, frequently you're keeping that knee hinged at that 90-degree angle, and you just kind of get like this sort of creep that sets into the tissues, and then that can actually create a bit of a functional problem that actually creates a knee pain that would look almost similar to somebody who is the running athlete.
Hmm.
So it can live on both extremes. The good thing is both you and myself and our offices are good at handling whatever the cause is. We'll get to the
Absolutely.
root cause of it and get some treatment on it and get you feeling better, right?
Definitely.
Yeah, yeah. So besides the front of the knee, because obviously we're saying front of the knee pain, and we're going on to where the pain is. So obviously it's on the front, but sometimes the knee and these chains are capable of traveling pains into other areas. Correct, Rebecca?
Definitely.
Yeah. Do you want to tell everybody about that then?
Yeah, yeah. So um, it's really interesting that sometimes the cause will feel pain either at the knee, right,
Mm-hmm.
and then, but it's not always necessarily caused right because of that tendon, right. So if
Correct.
I have pain in the front of my knee, right in that front part, a lot of times that's caused more from tension in other areas,
Mm-hmm.
especially a lot of those overuse chronic injuries that we see. I see a lot of that, like quad tension, right? Or like trigger points even in your quad or in your, the outside of your hip and everything like that can kind of really affect down the line. And same thing, you may have some referred pain if you have an injury to your tendon, right? It can go the other way. You might have pain either in a different spot in your knee or in different areas. And I'm sure you can elaborate more to that because
Yeah.
you've had a lot of experience with that way.
Absolutely. Well, and I know some people are just listening to this, they're not watching this, but you were not only just pointing up, going like up the thigh toward the hip, but you also kind of did that subconscious pointing
Mm-hmm.
down.
Yep.
So
Travels both
knee
ways.
pain can be tricky. It could radiate back up to the hip. That's why sometimes when people come in, it could actually be a little tough initially to assess, is this actually a more of a hip problem or is it more of a knee problem? Because
Mm-hmm.
if you have that whole chain taken up for pain, you actually got to figure out which one is the problem, and it can radiate its way down to about the ankle as well too. We were talking about this before, but effectively the knee is just a hinge joint. It just bends and it opens, right? It really just kind of has one cardinal plane of movement. So as a result, whenever we have pain in the knee, we're not dismissing your knee pain. You definitely have knee pain, but usually it's just not enough to only treat the knee pain and not work up into the ankle or the hip.
Mm-hmm.
There was an expression that we had in chiropractic school. I know they say similar things in physical therapy circles and whatnot, but the knee is a direct responder to the hip and the ankle, insinuating that yes, that might be the primary source of pain, but you almost assuredly have something secondary that you have to treat at the hip. A lot of times it's insufficient glute firing, and that's what's then making the pounding impact at the knee the most.
Mm-hmm.
But you could get somebody out of knee pain, but then if we don't go back and basically strengthen up the glute, then that person's going to be back in a handful of months anyway because we never address the full problem.
Correct.
Same thing at the ankle, like somebody's got a revved up super tight calf, which thankfully we basically work on the calf when we're working on any sort of knee.
Mm-hmm.
But again, if we don't fix out like that ankle muscular imbalance across the calf versus the tibialis anterior on the front, that person's just going to be back again. So we kind of have to work, effectively have to work with just about everything.
Yeah.
Yeah. So yes, definitely radiating up, radiating down. I agree with you on that.
Mm-hmm.
So, some of the common complaints, we were maybe already hitting some of these already, but in our running world, right, we're definitely going to kind of get like that sharp pain that kind of lives right at the bottom of the kneecap right
Mm-hmm.
there. I've kind of noticed, I think usually typically with runners, if it's front of the knee pain, they're actually going to complain more on impact. So there's
Mm-hmm.
kind of like the initial heel strike and then the follow through mid stance and then the power off. More of that anterior knee pain is going to shoot when they hit that heel strike. Is
Mm-hmm.
that typically what you see as well too?
Yeah, a lot of times with that heel strike, right? Because a
Mm-hmm.
lot of times their leg is then locked, right? And
Yes,
all that force that we talked about is shooting straight into that knee and it's causing a lot of issues.
one hundred
The other
percent.
time I will see it is with that full push off or the kickback
Mm-hmm.
as they're, cycling through their gait, just because it puts that knee on a stretch.
That's true too.
So it
Yep.
fires the quad a little bit.
Yep.
But that's not quite as common. I think heel strike is probably the most common complaint that I see with that gait.
Right, right. And then I think even when people aren't active, they're generally going to say, even though they're not, maybe they actually feel okay when they could kind of stay walking with like less impact, maybe cross training, being on the elliptical and being on the treadmill. But then sometimes crazy enough, then you have that injury and you're like, it hurts more during activity, but then it almost hurts more when you sit for long periods of time. And then you're
Mm-hmm.
like, why could that be? It's because then you effectively are taking those muscle chains that were injured in that one pattern and you're keeping that knee locked in that same pattern that created the injury. So that's why sitting for a long time could actually hurt quite a bit more.
Yeah.
I don't know if you've seen that as much, but I've seen that, and that's been a big educating point in our chiropractic office to help people understand why sitting actually is impacting lower extremity pain.
Yeah, definitely. We actually call that the movie theater sign. I don't know if you learned that in
No, I never
school,
heard
but
that. That's cool.
where you you sit in a movie theater for 2.5 hours watching a movie and you get up and your knee hurts,
Yeah,
right?
yeah.
We see it a lot with our student athletes because they have to go sit in class, right? They work out in the morning and then they have to go sit in class for 3 hours and they get up and they're like, my knee hurts.
And everything
right?
recontracts and tightens up, right?
Exactly, exactly. So super, super common in a lot of different populations for sure.
Absolutely, absolutely, yeah. And then, yeah, certainly, because we don't want anybody to really be too terribly left out as well, too. But you could certainly see anterior pain just as a result of osteoarthritis, right?
Right,
So if we're talking our
absolutely.
geriatric patients, people over 65 years old, that degenerative change and narrowing at the knee could be enough that it looks almost like a patellar tendonitis type of deal. The good thing is usually the treatment philosophy and principles are still the same. Treat it functionally, treat it with good muscle work, joint mobility, and small changes seem to make a big difference in our professions,
Right,
right?
right, absolutely.
Yeah, yeah. So I want to move into something that we call anatomical connections here. And actually, just we kind of alluded to some of this already, but just helping you to understand that the knee isn't just ISO. Yes, we always, when we're talking about treatment, we'll go in isolation and focus on the knee. But we kind of already talked about this before, the importance of really pulling the hip into treatment or pulling the ankle into treatment. One of my favorite things to teach patients and to empower them on is the understanding that there are actually these very predictable cross patterns, what we
Mm-hmm.
actually call the most classic one that people probably know is like the upper cross, where it's like I sit here, so therefore the back of my neck is tight, the front of my pecs are tight, and then the opposite, like the front of the neck is elongated and weak, and the back of the shoulders is elongated and weak. That's not what we're talking about here. We're actually talking about the knee down here. So we actually have a very predictable strong to weakness, like alternating pattern. And what typically happens is down at the knee, above the kneecap, there's the vastus medialis and vastus lateralis. Those are all parts of like the quad muscles.
Mm-hmm.
And quite frequently, rectus femoralis tends to be way too weak on a lot of athletes. It's surprising when you go to test that and you just like push it right down into the ground, and you got like that athlete that it's like, but I could like squat like 300 pounds. It's like, yeah,
Mm-hmm.
you could squat 300 pounds, but your rectus femoris can't stand the slightest breeze without blowing over. So that's why
Mm-hmm.
you have knee pain, right?
Yep,
um,
absolutely.
but you get that weakness through the front, and typically that's going to be accompanied by hamstring muscles that are way too tight, way too overactive. Now, usually there's a cross, but we find at the knee it actually doesn't cross. It actually kind of all stays on the back there. So we have like the tight, overactive hamstrings, and then we also get the tight, overactive calves. And then it's actually the front muscles on the front of the shin that tend to be a little too weak. So, like the tibialis anteriors and whatnot.
Mm-hmm.
Not 100%. We can't like look at somebody and say, I guarantee that's what it is, but we can make some pretty good inferences just because we know what lifestyles are. We know that many people spend way too much time sitting. We kind of know sort of like the adaptive behaviors that people fall into when they're walking and running to kind of work around like insufficient ankle mobility or an overweak glute. And those are just kind of like the ways the body just ingeniously adapts around things, but sometimes the rent comes due and the pain shows up, right?
Absolutely.
Yeah. So that's kind of what I wanted to share as far as an anatomical like connection, global connection. Was there something you wanted to contribute on that, Rebecca?
Just honestly, like kind of correlating with you, but I also look at joints. So not only the muscular tightness and tension and everything like that, but we kind of mentioned ankle mobility a couple of times, but
Correct.
sometimes that joint can actually be locked in itself, right? So less of a muscle tension, or it could be contributing because of muscle tension, right?
Mm-hmm.
But lack of mobility either in the great toe, the midfoot of your the bones in your foot,
Yes,
or like
yes.
that ankle, your classic ankle, what you think of as your ankle joint, right? That all can contribute to like lack of mobility or hypermobility there can
Mm-hmm, mm-hmm.
also contribute to some of that knee pain. And same thing at the hip, right? If you have restrictions in your hip or your mobility in your hip, that can also contribute to that knee pain because it may increase that Q angle that we talked about, or
Yeah.
decrease it, or change the way that you're moving, change those muscle pulls, which then causes some of that tension too.
Yeah, I love that you elaborated on that. And what I also think is, I was listening to you, but I was also laughing inside. It's like, isn't this just messed up that basically you had the chiropractor talk about the muscular problem and you had the massage therapist talk about the joint restriction? Aren't we supposed to like flip that around? But hopefully what that illustrates to everybody out there is that we do not put ourselves in a box. I think
Mm-hmm.
both you and I pride ourselves on really actually taking that extra 5 to 10% step working with patients, and not just thinking like, I'm a massage therapist, I'm just supposed to look at muscles.
Right.
And I'm certainly not I'm a chiropractor, I just move joints and bones. It's called the musculoskeletal system for a reason. You
Absolutely.
kind of can't really completely tease these two areas out. And I think if you just only really look at one and assess one and you drop out the other, you're not going to quite get the full results you want to get with patients.
Definitely.
So,
And I think it's great that we have these conversations too and can go cross collaborative, because then it's like I learn, he learns, right? We can both bring that into our practices too and
absolutely.
help our patients better.
Yeah,
So,
absolutely. So
yep.
now we'll step off of our soapboxes on that one,
Yep.
and let's move into our assessment philosophies. So, Rebecca and I, as we were talking about this, we realized there's some things that we do that are very similar on assessment, but there's also just like different lenses and different areas of focus that we put on when it comes to front of knee pain. Why don't you go first and kind of just walk through some of the big assessment tools that you like to use?
Yeah, definitely. So when I have patients or clients that come in with anterior knee pain, a lot of times what I'm looking for initially is I'll just have them stand and look at posture, right? I'm looking at their position, that Q angle, right? Their position of their knees, sometimes their patella mobility, how that patella moves, right? I'll look at their gait. So I'll assess
Yeah,
them
yeah.
walking, right? Looking to see if there's anything where I can see a restriction in that mobility, either at the knee or at the ankle or at the hip. And then on the table, right, we're doing assessments of moving that kneecap, right, looking at how that moves, because that actually acts as a lever for your knee. So if that's not moving or it moves too much, that can
Mm-hmm.
affect some pain, as well as just looking at muscle tension, right? Doing some tests. I sometimes will do some testing depending on the client, for strength testing and everything, but also just looking at muscle tension and how that's affecting their ability to move and function and range of motions.
Yeah.
So,
I wanted to ask one other question, just kind of right on cue with that, right? So you say
mhm.
you'll do gait assessment. You're typically doing, do you do shoe on or shoe off, or do you do both?
So typically I do shoe off because I like to
Mm-hmm.
be able to see how the foot moves.
Yeah.
If for whatever reason somebody's not comfortable with taking their shoes off, or they have some other dysfunction where they can't, we can do it shoe on. I just don't get that as much of a read on that
I
ankle and foot
Yeah,
mobility.
I fully agree. Plus, like, when you have the shoe on, you can't really see how that big toe's behaving too.
Exactly.
So like you can really start to get a better gauge if somebody's really walking, and then you realize like, oh, you get to the end and you basically pivot your foot because you don't have the ability to power off through your big toe. And if you're pivoting at the foot, like no wonder why your front of the knee pain is right there, because you
Hmm.
load it right at power off and everything. So
Definitely.
this is all the stuff that's valuable assessment. That's great that you do that. Full disclosure, I don't probably do as much in that in practice as I
Hmm.
should. It is so valuable. I don't quite do enough of it though. When I do assessments, I like doing a lot of assessments on the table. I actually always say that the number one thing we do, it doesn't matter if you come in with big toe pain or if you come in with hip pain, if it's lower extremity pain, we're actually clearing the lumbar spine first. You would be surprised the amount of times that somebody comes in and they say, it feels like I have a hip pain or a knee pain, and we actually assess the lumbar mobility, see how much restriction is happening there, and then sometimes we do just McKenzie exercises for the lumbar, and that pain gets like 70% better. And then it was the realization that that was never actually knee pain, that was full lumbar pain. And maybe no wonder why you went to this person for 4 weeks and had them hit your knee really hard and you didn't get better, because it never was your knee, right?
Hmm.
Um, that's still kind of more of the exception than the rule. What we'll typically kind of see is that it's kind of like a co-treat situation where, yeah, you got a problem at your knee, and it's still a really good idea to do some lumbar spine work, because that's where all the main nerve roots that make up like your sciatic nerve and your femoral nerve are coming from the
Right.
lumbar spine. So even if it only improves the knee by 5 to 10%, why wouldn't we take that 5 to 10% of improvement? But usually with the knee, I'm looking right at the hip. We'll get like a lot of hip baseline movements. We'll get the knee, because once again, sometimes there's only so much movement you can get at the knee. When we do like a block and try to test the extension at the knee, it's a really subtle joint play. Plus, even then, too, getting like heel to butt. At least the nice thing when we're assessing knees, though, I even jokingly say this in practice, is we have two of them. So in theory, the other side is normal, and it at
Mm-hmm.
least gives us an idea of like we at least have a little bit more of a better idea of a control and how your knee should be behaving. But trying to test out those ranges of motion, I'll do a handful of orthopedic tests just to make sure that we're not, in fact, dealing with like an ACL potential injury or an MCL. And if that does happen, then I'm usually sending them up the hill to Mount Nittany and say, like, go talk to orthopedics first, make sure they don't think you ruptured some sort of tendon. I want to clear that first, right? Um, but then I like also doing the functional muscle tests, like really testing like the two divisions, like the three of the main divisions out of the quad muscles, like the iliopsoas, hamstrings, and calf divisions. It's amazing how much weakness will turn on. And then we apply McKenzie method exercises. So frequently, not a hard fast rule, but if we're thinking something more like a younger student athlete or somebody that's like 40 and under and they say front of knee pain, they're typically going to do really well with the repeated McKenzie extensions at the
Mm-hmm.
knee. So opening up that knee. And it's amazing how sometimes just 15 of those and you take a muscle that melted down like warm butter and it's back to strong and everything. So that then gives the patients all the empowerment for how they need to keep getting better outside the office, and it guides us exactly how we're going to manage them in office. So
Definitely.
this does kind of tie into the how we fix it a little bit, but that's kind of the assessment that we use is a lot of functional movement, range of motion, some orthopedic tests, and then hit the McKenzie assessment. So, how do you like to treat front of knee pains? What are some of like your favorite fix it tools for from both your athletic training perspective and your massage therapy perspective?
Yeah, so a lot of times it's a lot of work in the quad,
Hmm.
quad, hip flexor, hips, and glutes. So depending on what I'm seeing from my assessment, right, whether it's, this is maybe more of a hip tightness issue, looking at those like glute weaknesses, are they having glute trigger points that's causing a rotation at their hip, right? All of
Right,
those
right.
things I'm kind of assessing, but a lot of times it's first just getting the quad to relax because 90% of the patients probably that I see, um, are if they have knee pain, their quad is lit up when they come to see me and it is very tight. So
Yeah,
getting that to relax is probably my first thing, whether that's compression, trigger points, we can do some stretching things. Um, and then also just, hitting those other points of the hip or the ankle if I see something with their, analysis that I'm saying like, hey, this might be causing that too.
yeah,
We might do some joint mobility and such. So
absolutely.
yeah.
All right, like all that. And so again, tons of soft tissue work.
Yep.
You tend to be like stretch space as well too. And
Mm-hmm.
again, just to try to highlight what I perceive as your advantage as a massage therapist is because you have this extensive athletic training, you're really able to kind of tie this into performance, maybe a little better than your average Joe massage therapist and everything,
Yeah.
because you have that experience and that connection and sort of have that understanding of how what we're going to do is globally going to start turning on these performances and these functions, right?
Right, right, definitely. And I think too, my big thing is I educate my patients right as I go, which
Yes.
we all try to, I think.
Mm-hmm.
But trying to get them to understand, hey, just because I'm working on this now, right? You have to go home and do the work too. You have homework, right? You
Yeah.
got to go stretch your quads. You have to go fire those glutes, right? You need to, sometimes I'll show them some exercises to go and say, hey, we're going to do X, Y, and Z with the band at the gym
Mm-hmm.
so that you can fire your glutes so that your quads stop taking over and
Uh-huh.
trying to do everything.
Yeah. Yeah. Well, as you can imagine, there's going to be some overlap with the things that we
Absolutely.
discuss. But from like mostly the chiro perspective, after we do our physical therapy and rehab assessment, if we could nail down and determine that that knee has a directional preference, which, like I said, for a lot of this anterior knee pain, it's typically going to be extension. Then I like to basically do stuff that's really driving that knee into what we establish the directional preference to be. So doing a lot of the kind of like the trigger points that you discussed, like working right into like the base of the quads, hitting up even sometimes up into like the rectus femoris. I like to really dig, even though the pain's on the front. I like to go after like the back of the knee too, and actually get some like release on popliteus, the hamstring tendons, the top of the calves, and everything. And it's really nice as well too, even though it seems wild to think about this because you can't really go deep into the joint, but it's actually wild the amount that we could do if we just take our thumbs and work through the joint line, how much pain and how much mobility that seems to put right back into the knee and pain that it seems to melt away. And then our favorite types of adjustments, typically, if it's going to be an extension responder for this anterior knee pain, the total knee extensions. So really kind of driving that knee deep into there, so that way you have that flexibility, that functional range back, and it's incredible how much that sort of shuts down the adaptive muscle patterns, and at least shows you how you could function the way that you're supposed to. So that way, in time, as these exercises start to take hold and we're able to turn back on that healthy, productive pattern with our treatments in office, eventually we take advantage of that neuroplasticity and actually get things to stick over time as well too. Couldn't agree more so with you though. Any sort of lower extremity pain, like the strengthening phase of treatment, is going to be absolutely imperative. Like
Mm-hmm.
we need to work on things like the one-legged balance stability to bring glute medius and ankle stability back up to speed. If we're finding that somebody just has a really overactive calf, then we might even go down and say, like, this is how you actually need to stretch your calf. But
Mm-hmm.
in reality, it's going to be a handful of things that have to be worked on. But it really doesn't take too much of modifying and cleaning up small little things to make a massive difference. I know
Definitely.
that's the second time I said that, but that's what we frequently find overall. It's usually not global massive changes that are putting people into pain. You just got to fix some of those maladaptive patterns and teach people how to keep themselves in proper function. And it's amazing the differences that you see.
Absolutely.
Yeah, yeah. So on that note, we did probably allude with some of our techniques here that we like to do. Some of those are going to drop as videos this month. So if you kind of like the actual visual of seeing something happening and not listening to us just talk, you're going to get some of that coming up this month. So definitely stay tuned to the chapter here. But otherwise, I think we're going to kind of wrap up our March of 2025 video here.
Awesome.
This was absolutely fun.
Yeah, I had a great time.
I thank you for coming on to our first ever podcast. I know this is our seventh installment for the massage therapy chiropractic collaborative approach and everything. But I've really had fun working with you for the first time, and I hope you're on for many more to come, because
Absolutely.
there's a lot that you bring to the table to teach patients out there, so that way we can have more people feeling better and also having them be empowered for the long run, right?
Definitely.
Yeah. Any other final parting thoughts from you then?
No, I don't think so. I just so appreciate you having me on. It's been great, and looking forward to continued collaboration. So,
Awesome, awesome. Well, I am Dr. Emery Pitcel. I, once again, of Rothrock Chiropractic and Rehabilitation. Just go to rothrockchiro.com. Find us from there. How about yourself, Rebecca?
and I am Rebecca Hall. I'm a massage therapist and athletic trainer with Happy Valley Bodyworks. HappyValleyBodyworks.com is where you can find us for scheduling purposes.
Yeah, yeah. We both have online scheduling abilities
We
because
do.
it's
Yes.
the 21st century. Why wouldn't you, right?
Correct. Just a convenience thing. You can call, but
Yeah, yeah. Well, absolutely. Well, thank you so much for tuning in. If you made it to the end of the video, if you want to leave us a comment about any sort of triumph you've had over your knee pain or any sort of struggles, we'd be happy to reach out and help you. Hit a like if you found this informative. If you know somebody in your circle and in your life who could benefit from hearing some of these videos or this podcast, send the link along, please. Big part of the reason why we do this is to try to educate people and to help them realize that they're not alone and that there are answers for them to get themselves better.
absolutely.
Yeah. And subscribe to the channel if you found it really awesome. We deeply appreciate that. Doesn't sign you up for anything. It's not a trick or anything. It just helps our stats. Okay. But yeah, from the B School, be powered, be empowered, and be better. I am Dr. Emery Pitzel,
And I'm Rebecca Hall.
and we will talk to you guys in April again, when it'll be just ever so slightly nicer, right?
We hope so.
Yeah, we hope so. Take care till next time, everybody.